All right, good afternoon. My name is Shantae Davis Patterson, and I am the program director for California's Comprehensive Cancer Control Program. We administer the State Cancer Coalition, the California Dialogue on Cancer, which is one of the coordinators for the California HPV Vaccination Roundtable. I'm happy today to be presenting to you our July session of the California HPV Vaccination Learning Collaborative. So just a few housekeeping notes here. All of you have been muted, but to ask a question, just simply unmute yourself when we get to that Q&A portion. Also, feel free to drop your questions in the chat. This webinar is being recorded, so we'll have it on our website shortly after. And as usual, we will have an evaluation for this session, so please help us by filling out that evaluation. Okay, so our little icebreaker today. We always like to know who's on these calls with us, so please, in the chat box, include your name, your pronouns, organization, your role, and our question today is, what is your go-to snack while you're working? All right. So, as I said, this learning opportunity is being brought to you by the Engaging Health Systems and Providers Work Group of the California HPV Vaccination Roundtable. So, what is the California HPV Vaccination Roundtable? We are a coalition of diverse partners who are working together to increase HPV vaccination. Our goal, as you see it on the slide here, is by 2035, at least 80% of 13-year-olds in California will be up to date on the HPV vaccination vaccine series. And you can learn more on our website at cahpvroundtable.org. And also, if you would like to get involved with the roundtable, we encourage you to do so. You can become a roundtable member and connect with statewide partners committed to preventing HPV cancers. You can join one of our active work groups to help shape projects that individual organizations couldn't pursue alone. Our work groups are engaging health systems and providers. We have a data work group and a parent and community work group. But you can see all of that on the website. And if you're not interested in joining a work group, you can simply just get on our mailing list to stay updated with all of things HPV vaccination that we send out. We work with a variety of organizations and all of our member organizations that have a lot to share in our frequent communications that we send out to our members. So scan that QR code, or as I said, you can go to cahpvroundtable.org to learn more about our membership and sign up. All right, so our agenda today. We're going to go into a few roundtable updates, and then we're having our feature presentation today, HPV Vaccination, Where Are We Now by Dr. Singh. And then we'll have a question and answer and close the session. All right, so a few updates. Save the date. We have secured our place for our annual meeting for the California HPV Vaccination Roundtable. This year, it will be in Sacramento at the California Endowment, Thursday, December 3rd. So save that date. And as I said, you'll get more updates if you're on our general mailing list. And now I'm going to turn this over to Bridget Freely, who's one of the leads of our parent work group, to talk about an exciting week that's coming up, the annual California HPV Vaccine Week.
Thank you so much, Shantae. Thank you for the opportunity to highlight this great public awareness campaign, California HPV Vaccine Week, which will take place on August 2nd through 8th this year. So some of you may be familiar with this campaign, but for those of you who aren't, just a little recap. California HPV Vaccine Week is our roundtable's annual statewide public awareness campaign that's spearheaded by the Parent Work Group, with the goal of really increasing awareness of HPV vaccination as cancer prevention throughout California communities. The campaign also really emphasizes the importance of vaccinating children between the ages of 9 and 12, and really aims to bring together partners across healthcare, public health, education, advocacy, and community organizations, really to share a unified message that HPV vaccination prevents cancer. So what's new this year? We've launched a completely refreshed California HPV Vaccine Week website, which now includes a variety of updated resources for partners and community members. And thank you so much, Joyce. I saw that you popped that in the chat. This includes updated social media assets, new testimonials from HPV-related cancer survivors and family members. We also do have a testimonial that we recorded in Spanish as well. We have messaging templates that organizations can use or easily adapt to fit their needs, and also guidance for individuals interested in sharing their own personal stories on social media throughout the week. So we hope that these materials really make it easy for partners to participate and spread the message that HPV vaccination is cancer prevention. A couple of other things I also wanted to share beyond the campaign materials is we are also working on a joint press release during Vaccine Week with several key healthcare partners, including the California Medical Association, the American Academy of Pediatrics California chapter, and the California Academy of Family Physicians. And we're really grateful for their partnership and look forward to amplifying the campaign together. We're finalizing that up in the next week or so, and we're just putting some finishing touches on the press release and happy to share that out once it goes live. And another exciting effort this year is a local op-ed initiative. We're working to identify lower performing counties with HPV vaccination across California, and then partnering with local advocates and community members to submit op-eds to local newspapers in those counties, focusing on HPV vaccination as cancer prevention. And I just want to shout out a special thank you to Adam from our data work group for spearheading this effort. We're beginning our efforts in Imperial County, and we're partnering with one of our parent work group members, Claudia Perez Favela, who's an 8-year cervical cancer survivor, patient advocate, and community health worker who lives in Imperial Valley. And she's written a fantastic op-ed sharing her personal experience with cervical cancer and highlighting the importance of HPV vaccination as a cancer prevention tool. And we really hope that this serves as a model for similar efforts in communities across the state. So we go to the next slide. We do need your help, and how you can help us is as we approach Vaccine Week, we're asking partners to help amplify the campaign in a few key ways. Please share the campaign website link with your existing channels. This can include newsletters, webinars, meetings, social media platforms. We did just send out an e-blast to the whole California HPV Vaccination Roundtable listserv. So you can absolutely use that announcement and share that with your networks. We also are asking individuals when sharing on social media, please share some of our content that we have ready. Please use the hashtags that we've identified here and tag the roundtable on Instagram and Facebook. That information is also on the website. And we are also encouraging partners to share personal stories on social media. We have instructions on how to do so on our website. We've really found that stories from parents, survivors, healthcare providers, and community members are often some of our most effective tools for increasing awareness and also motivating action. And finally, we also encourage organizations to work with their communications teams to pitch local and regional media stories that highlight HPV vaccination as cancer prevention and feature trusted community voices. And as I mentioned, we can share that press release we're working on once it's ready, if that would be a helpful template. Just to close us out, I just want to thank everyone who's contributed to this year's campaign. Encourage you all to explore the website and again, share these resources with your network. I also do want to note that I know we're really promoting HPV Vaccine Week, which is August 2nd through 8th this year, but we also really view this as a launching point for year-round HPV vaccination awareness and cancer prevention efforts. Many of the resources on this website are evergreen and they can be used well beyond Vaccine Week. So please continue to promote and use these materials as your HPV vaccination work comes up. But thank you everyone for your partnership and help with this campaign, and I'm happy to answer any questions if there's time.
Great. Thank you, Bridget. All right. And also, we wanted to let you know that the recording is available for the Western Regional Summit, which was celebrating 20 years of the HPV vaccine. Congratulations to the planning committee that took for planning this summit. that took place on May 20th. And that included some of our roundtable members, Jane Gray and Bridget Freely. This summit brought together diverse stakeholders to reflect on 2 decades of progress and discuss the future of HPV prevention across 13 participating states. Celebrating 20 years of the HPV vaccine, a Western Regional Summit on Prevention and Progress. Again, the recording for this is available on our website. All right, so just a quick update, what we always promote for engaging providers in health systems work group. The announcement approach training. The announcement approach training is still available. We still have Dr. Landau, who is our trainer, who is still available to provide this training free to anyone who wants it. You just contact us for the training. The announcement approach training, for those of you who don't know, presents strategies for recommending the HPV vaccine to promote vaccine acceptance and save clinical time. It's designed for providers interacting with parents. It's a 1 hour online interactive training, and you'll learn the latest on HPV vaccine research, guidelines, as well as brief evidence-based communication. So let us know if you'd like that training and we can help coordinate it. Oh, and also, we had CMEs for this and then they dropped off, but we will be getting them back in the next couple of months. So just an FYI on that. I don't have a specific date, but we should have them in, like I said, the next couple of months. All right, and for the data work group, I think Hillary is going to come on and give a brief update for the data work group.
Yeah, thank you, Shante. So I just wanted to piggyback on Bridget's comments about the op-ed project. It was an idea from Adam, one of our data work group members, was to actually act on our county level data. We had just come out of finishing the report that went through 2023, and we wanted to use that data to see what we could do in terms of an op-ed, bringing awareness to the communities. And so this is a partnership with the parent work group. We identified the 10 counties with the lowest completion rates, and we're working to identify local champions, and we're also checking to see which papers would be open to having us draft an op-ed. So we're working through our list. There is some overlap with Julie Dang's group in terms of counties, but we're really excited about it. Going county by county, identifying those champions who are willing to work with us on that, and securing commitment to do an op-ed. So we're excited to be using the data. And then back up to the first bullet, we're talking about creating some basic vaccination tables to share with you the data for 24 and 25. So there won't be narrative, just data, but we wanted to continue to get it out there. Thanks.
Great, thank you, Hillary. All right, and then a couple of more updates before we get to our feature presentation. The 2026 ACS Rural Learning Community HPV Vaccination and Cancer Screening Best Practices is going on. The session dates here are every second Wednesday of every month. The July session has passed, but the next one is August 12th. Joyce has dropped the link to register in the chat there. And then we have the 2026 Virtual State Engagement HPV Summit being put together by the American Cancer Society. This summit will bring together ACS staff, state coalitions, public health leaders, Medicaid and payer partners and other partners from across all the states to share strategies, strengthen collaboration, and support action-oriented progress. The session dates for that are July 21st through the 23rd, and Joyce has dropped that in the chat. Thank you. All right, so now we are getting to our feature presentation. And we are going to drop the bio for our speaker in the chat. So please do take a minute to read her bio. But today we are going to hear from Dr. Singh, who is the Assistant Director and Medical Epidemiologist at Children's Hospital Orange County, or CHOC. Again, Joyce has dropped the bio in the chat. And without further ado, I'm going to turn it over to Dr. Singh.
Thank you so much. It's really a pleasure to be here with everybody today. And I'm going to spend the next 20 minutes or so going over sort of the newest updates regarding HPV vaccine. And really, I know that all of you already know a lot about this topic, so just sort of the most recent updates and some work that we've been doing here at Rady CHOC as well to help further this work. So thank you so much. Next slide, please. Next slide. So all of you here know this, but there are millions of new genital HPV infections in the US. Most of those infections are asymptomatic and transient, and where we get into trouble is with persistent infection with the oncogenic or cancer type HPVs. And that's where our vaccine has been so important. Next slide. So this is older data, but the numbers have not changed that much. And what I really like about presenting the data this way is that it really shows us that cervical cancer is sort of the tip of the iceberg on this pyramid. So we're familiar with the numbers about cases of cervical cancer, but you know, I think that most of us have friends, family, someone who's maybe experienced some of these other morbidities like cervical dysplasia, high grade or low grade, or even cervical or genital warts. And those numbers, of course, are even higher as you go down the pyramid, so that the total burden, even just in terms of female cervical disease, can be quite high. And for anybody who's had to go through an abnormal pap smear and maybe biopsies, colposcopies, it's very distressing to say the least. So all of those things sort of underneath the tip of the iceberg, I think are underappreciated. Next slide. And this is one that I'm sure that you're all familiar with as well, looking at some of the other HPV attributable cancers per year in the US. And you can see that there are other GU cancers, which all of you may be familiar with, and it's sort of broken down into males in the navy blue and females in the purple. And I think you can appreciate that now there is actually more oropharyngeal cancers than cervical cancers attributable to HPV, which is really interesting, and I think really just starting to garner a lot of attention from people. And those oropharyngeal cancers, as most of you know, are even more of a problem in sort of middle-aged men. Next slide. So here's a problem that I want to talk about that isn't on any of those graphs, but as somebody who's done pediatric infectious diseases now for 30 years, I've seen a number of these cases, and you know, one of those things that's uncommon but can be very refractory and difficult to deal with, and doesn't get talked about as much. So I'm actually going to have whoever's driving the slides for me go forward 2 slides, and we'll come back to the picture. So respiratory papillomatosis in children is a rare disease, and what happens is that the baby is transmitted HPV, the types that most likely lead to warts, like 6 and 11, from an infected mom. The baby sort of gets colonized and then infected during vaginal delivery. And that HPV sets up, it seems to have a tropism or want to go to the larynx and the upper airway, and it kind of sets up shop up there. And a couple of years later, these toddlers start to present with first a hoarse voice, then stridor, which means inspiratory difficulty, and then just frank respiratory distress. And it is, as I mentioned, a very refractory kind of disease to deal with. So these papillomas are benign, they're like warts, but they're just very hard to get rid of from the larynx and the upper airway. So we have to do surgical debulking. Sometimes our ENT doctors try to inject antivirals into these things. And, these treatments often have to be done over and over again. So please go back to the last slide there, and I want to show you what that looks like. And really what you see on these two views are these sort of warty growths, kind of a cauliflower appearance, if you will, that are not normal in the larynx. Normally these walls would be very smooth, and you can get the sense of these sort of bumpy growths. And you can also get the sense from the picture on the right that there's not much of an airway left in there, that these growths are encroaching on the airway. And so you can imagine that this poor little toddler whose airway is not huge to begin with now has a very narrow opening because of these growths. And the surgeon has to go in, try to remove them. They keep regrowing, all kinds of problems. So this is one, as I said, it's rare, but really, really difficult for families and the treating physicians to deal with, and something that I've seen several times in my career, but we don't hear about that much. Now go 2 slides ahead again. Thank you. And so I wanted to see what the data on this was, because in my own personal practice, I have seen a lot fewer of these cases, in the time that we've been vaccinated. And I thought, well, gosh, somebody must have looked at this and can speak to it more than just my anecdotal experience. And sure enough, there is this paper, which is a 19-year retrospective cohort study. And I took these graphs straight from the paper, and you can see, I think, pretty clearly that as the incidence of HPV vaccine went up, the incidence of recurrent respiratory papillomatosis went down over the last 2 decades. So pretty striking, and certainly in line with what my personal experience has been. Next slide. So everyone here on this call knows all of this. We started with the quadrivalent vaccine. We were trying to hit 16, 18 that were related to oncogenic or cancer-causing types, and then the 6 and 11, which cause the vast majority of warts. And then for many years now, we've had a 9-valent vaccine giving us about 15% more protection against cervical cancers. And one of the things I think that always comes up is, can the vaccine give us infection? And this vaccine, of course, cannot. So this vaccine is made up of what are called viral-like particles. You might see that in the vaccine literature, VLPs, and these are the empty shells of the structural proteins of the HPV virus, but they have no genetic material in them. So this vaccine cannot give you an infection. Next slide. And then, of course, everyone here probably is also aware of the fact that this vaccine is more immunogenic when given at a younger age. So we have our 2-dose regimen if we're giving the vaccine at less than 15 years. And if we're starting at 15 or more, then we need 3 doses. So that's always an incentive to get people to get the vaccine in on time. And we always remember that our immunocompromised patients, so kids with malignancy, HIV, anything else, they all need to get a 3-dose schedule no matter what age they're starting at. Next slide. So, of course, the routine immunization age has been 11 to 12 for many years, with catch-up at 13 to 26 for both boys and girls, and then recommendation for individual clinical decision-making for people in their young adult years, I'll call it, 27 through 45. And we certainly know that this vaccine has incredibly good efficacy and long-term durability. Next slide. So where are we going now from here? So I wanted to let everybody know about this Vaccine Integrity Project review that just came out in May, so not too long ago at all. So the Vaccine Integrity Project is out of the University of Minnesota, and I think with all the changes at HHS and some changes with the ACIP that was previously very effective, there were some concerns about vaccine recommendations, and so this project was developed to really take the place of what the ACIP was doing, which is to do a really good overview of vaccine studies, review the evidence, and help the AAP and other organizations with recommendations. So this is their review that just came out, and this was a very systematic meta-analysis looking at the safety, efficacy, and the effectiveness, immunogenicity of HPV vaccines in the United States. And they looked, I think, at some of the concerns that you hear about from parents. So POTS, right, which is this sort of vaguely understood postural orthostatic tachycardia syndrome, chronic fatigue syndrome, otherwise known as some of those other acronyms there, Guillain-Barré, premature ovarian failure and infertility, which have also sort of made the news and gotten people concerned. So the report itself, I think, is really worth reading, but their conclusion is that we assessed whether any new safety signals following HPV vaccination have emerged that merit further investigation. And across the 25 studies in our updated review on vaccine safety, we found no association between HPV vaccine and all of those outcomes of interest, and that their conclusion is consistent with those of recent Cochrane reviews. They also looked at effectiveness and concluded that the available evidence supports a strong and favorable safety and effectiveness profile, with findings broadly consistent with prior Cochrane reviews. Next slide. HPV vaccines provide substantial protection against cervical cancer and some of those other things on that pyramid that we started with, the high-grade cervical lesions, persistent HPV infection. And they started to delve into this piece about single-dose schedule, and that it may offer protection comparable to 2- and 3-dose regimens for key outcomes in females, particularly cervical cancer. And so that merits ongoing policy discussions around dose reduction. But there are evidence gaps still for male populations, non-cervical cancers, and long-term durability of single-dose protection. So it's a really nice, really complete review, and overall incredibly encouraging. Next slide, please. So this is also a paper that just came out very recently in The Lancet, and I thought I would share with you. And this one is from England, and what they looked at was findings between 2020 and 2024 in women between the ages of 20 and 24. And you can see from their data here on this particular graph, which I think is just remarkable, is they looked at their crude rates, right, by which are the circles, and then they smoothed those out, which are the blue line. And in unvaccinated women, they showed crude mortality and where they would have expected to be with this scatter plot around it. And you can see that England, with their very effective program, 90% uptake, has in this age group almost eliminated deaths due to cervical cancer in this age group. I mean, it's really just amazing. And in their conclusion, the authors suggest that elimination is possible because, of course, as we know, HPV is so tightly linked to cervical cancer. So this is also another paper that I think is just remarkable data and really taking a look at. Next slide, please. So, like any other paper, there are going to be the naysayers, and particularly for those who are not vaccine enthusiasts. And so some of the comments about this paper are that, well, the increased survival is from screening rather than the vaccine. And what's interesting is that England actually raised its screening age during this time. So that is clearly not the case. They didn't do increased screening during this time. They actually did decreased screening. So I don't think that is a valid point. Another concern has been, well, this is just some kind of statistical fluke. And I really don't have a good counterpoint to that except to say, wow, that's we can say that about almost anything, right? And that doesn't seem like a good scientific counterpoint when we're talking about looking at so many studies. And that finally, the naysayers, well, it's just less sex. And my counterpoint would kind of be also, once again, really, but they've actually looked at STIs over this period of time, and there is no decrease. So I don't think that that's likely a valid point either. So, I think that there are the criticisms of this paper, but I really am not finding them very persuasive compared to the actual data in the paper. Next slide. So how are we doing with our HPV vaccination rates in the US? So this is, 2024 data. This is what we have right now. And this is adolescents ages 13 to 17 with up-to-date HPV vaccine series. And so you can see here that sort of purple is less and the black is darker is good in this case. And so, of course, we all know that HPV vaccine works great, but it can only eliminate cancers if it's administered. So in 2024, if you look across the board, 79% of girls and 77% of boys in this age group had received at least one dose. And the range in the states, as you can see from this this map here, is huge. So adolescent girls with at least one dose range from 85% in Massachusetts, which is doing a very good job with HPV vaccination, down to 57% in Mississippi. So that's just a huge difference. And I think that this map is really very telling that way, that we have such wide variation within our own country. And so, really dialing into some of these differences, adolescents living in rural areas, uninsured kids, and those from lower income families have lower vaccination rates. So it's a combination of access issues as well as vaccine hesitancy, I think. You can see here from this map that overall California is doing relatively good, though not the best. Next slide. So where are we going from here? The emphasis, as you all know, has always been on getting 11-year-olds immunized at that sort of preteen vaccine platform when we give HPV, Tdap, and meningococcal vaccine. And the AAP for some time has actually been recommending vaccine at 9 to 12 years. And we know, of course, that the younger you give this vaccine, it's more immunogenic. And the question has been, well, if we did it younger, would we do better with completing the series? Certainly younger kids are more likely to come into their pediatrician for their yearly checkups. It's a lot easier to get a 9-year-old, 10-year-old to come in than it is to get a 12 and 13-year-old to come in, as we all know. And then, we would like to think that there would be less discussion about HPV as an STI at that younger age, and really more discussion about HPV vaccine being this powerful anti-cancer vaccine. And that's the discussions that we want to have. And, another potential benefit might be that, it'll be less shots at that one preteen visit. We're spreading them out a little bit. And then another potential future recommendation, as I mentioned and was mentioned by the Vaccine Integrity Project, is the single dose schedule, which has been reviewed by the SAGE committee of the WHO a couple of years ago. Next slide. So what I wanted to do then is address that question about age at first vaccination with you by looking at a study that we are finishing up with, kind of getting into this year 6. And this is a study that the primary investigator is Dr. Shalagi, and I think everybody here is familiar with his just mountain of work in the vaccine space, and particularly in the HPV vaccine space. So we were lucky enough here at CHOC, myself and my colleague Dr. Golden, to be able to work with him on this project and be one of his sites. So he just gave us here at CHOC a data summary at Grand Rounds, and so I thank him. I have completely plagiarized the next few slides from him. Next slide. So this is the HPV early intervention trial that we started back 2020-21. Next slide. And so it was really asking those questions that, I just mentioned and so many people are asking. Does vaccinating at age 9 by itself, not combined with other interventions, raise initiation and completion in a timely way? Does it increase completion by age 13, which, as you know, is HEDIS and other measures? Is it feasible? Does it change the relationship? Does it change the discussion? Are there any negatives of doing it? Next slide. So the way this study worked is that there were 31 practices, some of which were in Colorado, some of which were in California, and the California ones were at UCLA, which is where Dr. Shalagi is, and then here at CHOC, where I am. And the practices themselves got randomized into 2 groups, a 9-10 group and an 11-12 group. And everything else was really kept to the same. So both sets of practices got training modules on improving HPV vaccination, communication, all of the good things. But the only difference is the 9-10 study arm had a little added addendum piece to their training about switching initiation from 11 to 12 down to 9 to 10. And you can see what some of the training was for both study arms, a lot of the good work that you guys have been involved with here. And that was the only difference. So it was really just that single intervention. Next slide. And so I'll just skip to the results here. And basically, you can see that the intervention arm did really well. So the red is initiating at 11 to 12, and the blue is initiating at 9 to 10. And you can see that whether you look at completion at age 13, or you look at initiation, the groups that were starting at ages 9 to 10 did significantly better. There's a big gap there, anywhere from sort of 7 to almost 26 points, depending on the practice. And I think that you can really appreciate how dramatic this difference was. I think honestly it was more than what we were expecting. Next slide. So early initiation was acceptable to most patients, acceptable to the providers, effective in raising HPV vaccine initiation and completion, raising the HEDIS measure, which to be vaccinated by 13. And I didn't go into all the specifics of the data, but it really didn't change the conversation much. And it seems to be another intervention that can really work. Next slide. So the other question, of course, that I raised was that whole issue of single dose. And so the AAP has established an HPV subgroup to review, and I think they're meeting at the end of this month. So I'm really curious as to how that discussion is going to go. And we know that single dose results in lower antibody titers than 2 to 3 doses, not a surprise, but does this matter clinically? In other words, if you have enough of a buffer, does being here versus here make a clinical difference? It's a little bit hard to establish because the exact minimum antibody threshold is not completely ironed out. And then, of course, the long-term durability of those antibodies are a question. And as we mentioned, there's not as much data on cancers in males, including like oropharyngeal cancers, which we know are a significant problem right now. Next slide. So I'm just going to conclude with some of the work that I'm doing, and I'm sure that all of you are doing in terms of training the next generation of vaccine champions. So I do a lot of teaching here and a lot of teaching on vaccines in general. And one of the things that I think I've noticed over the years is that for the different vaccines, when you're training younger people, in my case, medical students and pediatric residents, sometimes it's harder for them than for people in my generation because they didn't see very many of these vaccine preventable diseases. It's easier for me, who saw a little, quite a bit of hip disease in my day, a lot of strep pneumo disease, all of these things, to sort of get very worked up and agitated about getting people vaccinated, and harder for those younger trainees when they really haven't seen those diseases and have seen how bad they can be. And the same, I think, is true for HPV in a different way. The repercussions of HPV vaccination really aren't seen for several decades, so not as obvious. And I think a little bit harder almost to conceptualize for people who are pediatricians. But one of the things that I do, or I'll mention a couple of things, is I do a session with them every year, play acting, if you will, on vaccine communication, where I bring in general pediatricians from the community, and I have scenarios, about 5 or 6 scenarios of different vaccine hesitancy issues, and I have some of our infectious disease doctors play kind of ornery vaccine hesitant parents, and the residents have to literally talk, do a simulation talk through with them, and I have our general pediatricians from the community who are so good at this kind of critique them and give them words of advice and encouragement. So we definitely have an HPV vaccine scenario in our training. And I also give them a vaccine quiz every year and have HPV questions on that as well. So other ideas for training the next generation of vaccine champions I would love to hear from, and I'd love to hear from everybody else about their other experiences as well. Thank you so much.
Wow, thank you so much, Dr. Singh. That was an amazing presentation with a wealth of information. And yes, Dr. Salaji is a friend of the roundtable, so it was
Oh,
great that
yes.
we got to see some of that there. We are almost at time, but if you have a couple of minutes to, we have a question in the chat. If you don't mind just staying on for a couple of minutes to answer that, and anyone else who can stay on with us, that would be great. The question that we received is, when can we expect AAP to make an announcement and any insight into what their recommendation would look like for one dose?
I think we'll have more information really in just a few weeks when that AAP, the Committee on Infectious Diseases, meets. I'm pretty sure it's at the end of July. So I think that they'll be saying something, whether they're going to say we need X more data or, we're ready now. I'm not sure, but they will be saying something. So I'm really actually anxious to hear about their discussion.
Yes, yes, as I think we all are.
Right?
Yes,
Yeah,
yes.
yeah.
There was just a comment that says, what a comprehensive update of what is going on in the world of immunization. And it absolutely was. So again, Dr. Singh, I want to thank you so much for joining us, for giving us this wonderful update. And to everyone else who joined us today, um, thank you for joining us and spending your lunchtime with us. Our next session will be in October. Remember, you can get involved with the roundtable there. And if anyone wants a training or anything like that, just go ahead and contact us. And again, this recording will be on our website. Lastly, before anyone leaves, please just link to our evaluation, and if you can fill it out before the end of the day, that would be great. Thank you again, everyone. And
Thank
thank
you
you,
so
Dr. Singh.
much.